This is Healthcare Now, radio's trending now. Get ready for an exhilarating 30-minute ride through the latest topics driving change in digital health across the news and social media. Join us as our subject matter host takes the lead in uncovering what's hot and what's not. So buckle up and tune in to stay in the know.
This is Trending Now on Healthcare Now Radio, where we explore the forefront of healthcare innovations and transformations. I'm your host, Shahid Shah. Welcome to this special episode, recording live from HIMSS26 in Las Vegas, where I'm going to be speaking with two guests. First, we're thrilled to have Lauren Barca, Senior Vice President at 86 Borders. Lauren, tell us a little bit about yourself and what brings you to HIMSS.
I want to say first, thank you so much for having me on your podcast. I am a population health nurse who got into the healthcare and care coordination space during my career. I love coming to HIMSS. There's so much innovation here, so many new ideas. It's great to see what's on the forefront of technology and clinical outcomes.
Great. And what's your favorite part of HIMSS? Is it the people, the networking, the sessions, or maybe the exhibit floor?
Well, I have to be honest, there's a puppy park upstairs where you can play with puppies, and that was a lot of fun. So I have to tell you, that's been my favorite part so far.
That is awesome. It's always the smallest things that don't seem like anything to do with healthcare IT that are people's favorite parts.
Yeah.
So that's awesome. So tell us, you have a very interesting story about the name of the company. Tell us what's behind the name 86 Borders.
Yes, 86 Borders was founded by our CEO, Dan McDonald. And I'm not sure if you've ever worked in the restaurant industry, but 86 means to get rid of something, take it off the menu, you're out of it, you're cutting it off. So you're literally getting rid of it. And so our goal and mission is to 86 or eliminate borders to care. Our hope is that everyone can have the access that they need to the healthcare services, to the social services, to the benefits that really drive clinical outcomes.
Yeah. And what do you think the top 2 or 3 borders are that you're trying to 86?
Yeah. Health plans spend so much money on benefits, on expanding networks, and even having outcome programs that they drive. And what we find is that there's a huge gap in people being able to access those benefits. So just having insurance doesn't mean that you know how to use it. It doesn't mean that you can figure out how to navigate the network. And beyond that, people are dealing with really day-to-day crises: housing, transportation, food, any kind of social barrier. And so our goal is to really eliminate the things that are keeping someone from being able to access the care. So sometimes it's removing those SDOH needs. Sometimes it's helping them identify, locate, and even schedule an appointment with an in-network provider. It's helping them understand what that insurance card means in a way that they can understand it, whether it's in their preferred language, whether it's walking through complicated documents with them, whether that's helping them access other social services, such as SNAP benefits, WIC benefits, Social Security benefits, things like that, where it can be very complicated for a person to complete on their own.
Yeah, that's outstanding that you're able to handle all of those kinds of borders that you're trying to 86. Now, I often like to say that in the United States, there's no business model to do the right thing in healthcare, which means that a lot of what you're trying to do, which costs money to someone, and the access often is hard to get because it's disjointed. Payers pay for certain things, providers pay for other things. What have been some of the challenges that you've seen in getting people to understand what the access challenges are, which can then actually be taken care of because the money is available or the approaches are there? You have to be almost like herding cats in this case. So what does that look like?
Sure. There's a lot of disparate groups, and our job is to connect the dots across the payer, the government, the provider, and even just community resources. So one of our main jobs is to make sure that everyone knows what's going on across the healthcare spectrum and ecosystem. Beyond that, though, to your point, we have to somehow deliver a return on investment because it costs services. It costs money to provide the services that we are providing. And so when we're reaching out to what has historically been an unengaged population, a population that frequently uses the ER, those that can cost a lot from an inpatient perspective, we have to realize that the ROI is in getting the most vulnerable engaged in the right care at the right place at the right time. And that is where we think we're making a difference in the healthcare space, is because it's historically non-compliant. I don't love that word, but that's, the word that's used. People who have barriers to care are the ones who can be the most costly. So when you can figure out what that barrier is, you are able to provide an ROI to the healthcare system.
Yeah, that makes sense. I mean, euphemistically, we use terms like frequent flyers and, like you said, the non-compliant, but they are meaningful definitions in our industry. So give us an example of what is a recent engagement that you've done that would be surprising to most people, that there is a way in the United States, even though all of these are disjointed and disparate facilities, that somebody like you guys, like 86 Borders, can actually come in and make something happen, not just talk about it and not just describe what it is, but tell us, like, what is a recent engagement that could help bring this down to earth and explain what you do?
Sure. So we have so many meaningful member stories. I'm going to tell you one today about Maria. Maria was a 70-year-old member that we had provided to us from a payer we got her name off of a list. She had diabetes, she had hypertension, she had not gone in for her annual wellness visit, she had not picked up her diabetes medication at the pharmacy. So she kind of came over to us. She was a DSNP member and concern about what's going to happen to her. And she had a history of frequent ER use. When we were able to contact her, the health plan attempted multiple times to reach her through phone and through letters and things like that. What makes us different is that our care coordinators are local to the populations that they serve. They're calling from the same area code. They live in the communities. Maria spoke Spanish, so we connected her with a one-on-one care coordinator who also spoke Spanish and lived very close to her. She started trying to figure out what was going on in Maria's life. What was the barrier to accessing the care? And through listening, through empathy, through trauma-informed care, the care coordinator learned that Maria was dealing with raising her 3 grandchildren and was really overwhelmed, had some food needs, had some diaper needs. So before we even started talking to Maria about the need that it's time for your annual wellness visit, it's time for your mammogram, before we even said those words, we made sure that our priority was to close out those social barriers for her. We connected her with a diaper bank in her area that would provide diapers for her grandchildren. We connected her with a clothes closet to give clothes to the kids who needed the clothes in order to be able to go to school and daycare. We connected her with food assistance. We reviewed her SNAP benefits with her, and all of this, before we even started talking to her about things like mammograms and preventive care. And then we started thinking, okay, what's the next most important thing? Now that we kind of have this immediate need taken care of, what else can we do? So it wasn't just focusing on Maria, it was an entire family approach. We looked at the housing situation and we got her on a housing wait list for a new place to live. We started then talking to her about her diabetes medication. What can we do to get her metformin home delivered to her at a 90-day? So we worked with the her previous primary care provider. We got her reestablished into that primary care provider. We worked with a med delivery company to get that sent to her, and then started just working through down the list. And through months and continued engagement in that trusted human-to-human relationship, we actually closed a lot of gaps for her. So at the end of time, working with her, all of her gaps in care were closed from a STARS and HEDIS perspective. She had not been to the ER. She was in much better place. More than that, though, she had the direct phone number to her care coordinator and could reach out and agree to an ongoing relationship. So we still continue to talk to her, check in on her, see how things are going, and she'll reach out to us and say, I have this new need, and we're able to help find a way to help her meet that need.
That is such an awesome story. And what's most impressive about it is how thorough you guys were. So tell us a little bit about the business relationship here then is, are you getting your attributed patients directly from health plans, or is it a mixture?
Yeah, we mostly work with health plans. We have worked with the health system, but really we're thinking about how we can help the most vulnerable populations, whether that be Medicare Advantage, the SNP populations, Medicaid, Marketplace, I think is a really important area to look at, and even veterans. You know, we're thinking about where there are disparities and where there is a need to really be this thorough in the population to drive improved outcomes for both the patient and member, as well as the health system and the health plan.
Nice. And what would your preference be for listeners of your story, especially that was such an awesome story? Who should be calling you to get your help in these particular ways? Would it be, what kind of role or person would it be at a health plan or a hospital health system that might reach out to you?
Sure. A lot of times we start in the quality team. Someone who's looking to improve their HEDIS will come to us and we say, we do so much more than that. We're incredibly holistic. We talk a lot to finance teams who are trying to figure out their inpatient and ER usage. We talk to CEOs, COOs, anyone who's looking to improve their outcomes.
No, that's great. And so in these cases, explain why what you do in a thorough way helps with HEDIS measures and improving the STAR scores, for example.
We're not a one and done. We like to think about a member holistically. And if we're able to invest in a member holistically, they have so much better outcomes across the board. So it's not just an improvement in the breast cancer screening HEDIS measure. That's minimal. What we're doing is thinking about long-term cost savings, driving appropriate utilization, sending the member to the right place at the right time, which will really help reduce costs for everyone.
Now, what do you see as lots of people think that you can just buy a piece of software or technology, especially sitting at HIMSS here. There's this thought that maybe we can make all of this happen with AI. Talk a little bit about that. We have about a minute left. So tell us a little bit about why technology certainly does help and where it's helped you guys. But what does technology lack that wouldn't be able to help in these areas?
Sure. I think AI is going to be incredibly important as we move forward, but I still think there's going to be such a need for that human-to-human, builded, trusted relationship. It's how I would like to receive my care, and certainly the most vulnerable historically tend to be very distrustful of the healthcare system in general. And then when you put an AI agent in front of them, I think it would be incredibly unlikely that they would be responsive to that modality. So I think from the back end, it's perfect to how we can make our care coordinators and case managers more efficient. But at the end of the day, it's a human having an unscripted conversation with a human, listening to their needs, adapting the conversation to exactly what that member's needs are, and then acting to completely close the loop.
Awesome. Just one quick last question then. What does the scale look like for you? Are you dealing with thousands of patients, tens of thousands, millions? What does that look like? Sure.
We have about 1 million members right now in our system. So it's a big lift, but we're so happy to take on the challenge and we're excited about the future.
So that's great. I just want to make sure everybody heard that you can help more people.
That's right.
Lauren, thank you so much for taking time out of your busy schedule at HIMSS to share your insightful perspectives with us. We're going to hope that you come back later in the year and tell us how you're doing. Did you get to 2 million members or not? So thanks a lot.
Oh, thank you so much for having me.
Absolutely. Welcome back to our live recording at HIMSS26. I'm your host, Shahid Shah. My second guest is Michael Meucci, CEO at Arcadia. Did I pronounce your last name?
You got it. You nailed it.
All right. Awesome. Michael, so tell us a little bit about yourself and what are you doing at HIMSS?
What am I not doing at HIMSS? I'm running around getting my steps in. I'm gambling. I'm learning all about the transformative power of AI, learning about the early successes, some of the challenges, and thinking about where we're going to be in 5 and 10 years. Arcadia has been at this for a long time, started the business 15 years ago with the mission of fixing healthcare's data problem, and really excited about the progress the industry has made. I mean, I think this is my 10th HIMSS. If you think about what's changed from the early days where everyone was selling an EMR to help physicians bill more for their encounters, through the, clinical decision support, computer assisted coding days, through the data platform population health days, now to the AI days. It's a fun place to be in an industry that people don't think changes that much. It is changing incredibly rapidly. And it's not a new thing. We've been changing for a long time pretty rapidly.
Yeah, you're so right about that. And so far, what's been your favorite part at HIMSS? What surprised you more than anything else so far on what you've seen? It's only the second day, so.
I think what's really surprising is, unlike any of the technology transformations we've seen in the last 10, 15 years in healthcare, I think we finally see people saying, I'm going to challenge conventionally accepted wisdom. I have heard over the last couple of days, why do we just accept that a health system is going to run on a razor thin margin? We don't have to accept that anymore. Or why do payers and providers have to be so adversarial? Can we work together better? Or why can't consumers have their data? I can't remember what year it was, but there was this common refrain of like, Dr. Google, and it was such a bad thing. Now you've got Claude and OpenAI giving consumers access to their health products powered by their medical records. And you have healthcare organizations saying, yeah, let's figure out how to open the data and have that be part of the care team. So I'm pretty impressed by the neuroplasticity of the leaders in this industry. I think some of it is that you can't deny how good this technology has gotten. And we're early days. I mean, you have to think about ChatGPT was released 2.5, 3 years ago, and now it's ubiquitous. You have products like Open Evidence just taking the physician market by storm. So I think that there's just this awakening of how different can the system be in 5 or 10 years. And you have a lot of really innovative leaders who want to be the usher of that change in, because we're at a point where healthcare has to change. There's margin pressure everywhere. There's access issues. We're not producing as many doctors as we once did. We don't have enough supply to meet the demand. And all of a sudden, there's this great set of technologies. I'll stop rambling in a second, but I love literature, always have. And my team has heard me say this all the time. One of my favorite passages is the opening of A Tale of Two Cities. It was the best of times. It was the worst of times. And it goes on with these juxtapositions. And that's what we live in. You think about from drug technology, we live in an era where we are meaningfully impacting the obesity and chronic disease epidemic with GLP-1s if we could just figure out how to afford them. We have AI tools that can meaningfully reduce the administrative burden in healthcare and start to reduce the transaction cost. But payment models have to catch up and figure out, how do you reimburse for a robotic visit? You have new payment models like the access model that are starting to drive that through. But it's this convergence of pressures that I think is creating some really special conditions that will make us a much better healthcare system overall.
Yeah, I totally agree with those sentiments. And the thing that surprised me most is, so you had the fall of 2022, which is the introduction of ChatGPT. And typically you hear health systems saying, okay, we need to first think more a little about this. We need to set up our governance committees, et cetera. Nowadays, they're just throwing things in and seeing how things work. And this is very unlike, even your example of Open Evidence. The speed at which it was accommodated is only probably surpassed or matched by the original iPhone moment.
Yeah.
So software had never moved that fast because there's always been barriers to get into those environments. And now the docs and everybody are like, I don't care. We're burned out. We're going to do what we need to do. You guys, you have to catch up. Now, to catch up, I'd love to hear, you guys have been in the data world for a long time. To me, now, most of it seems like most of our problems are solvable with the software we have in place, but we still have all the data challenges.
Yeah,
Talk about that.
We still send like billions of faxes. It's crazy. There was this article a couple of weeks ago in Medium. It was a Citrini piece about the global intelligence crisis in 2028. And it made the rounds in like my Wall Street friend circles. And, they were like doomsdaying about it. And then got to my healthcare circles and we were all kind of laughing at it, being like, we've never solved our data problem. And data is still fragmented. It's siloed. Healthcare workforce is a really important workforce. When you think about the US's jobs data, if you took all healthcare jobs out of jobs data, unemployment is rising. Healthcare has continuously saved the economy. And it's a very, very important sector. And it's very important that we protect it. So what I think is so interesting is there are people who say, wow, we're going to automate a bunch of administrative jobs in healthcare. But just like these other human capital revolutions, whether it was email or word processors, those individuals don't leave the workforce for good. They reskill, they upskill, and they do new things. Who's going to manage all of these AI agents that are doing coding and documentation? When you think about a CDI team today in a health system or at a health plan, they have managers, they have productivity metrics, they have evaluation frameworks. Yes, AI can in some ways self-govern, but you can't let it run away with itself. And so there's going to be a whole new set of resources we deploy over the next 5 to 10 years, companies like ours that'll help evaluate, measure, and performance manage agents with great data. And so I think that we're on the early days of a new workforce revolution.
Yeah. So, there's a common adage on the left coast as it is in innovative circles that often we, especially in the innovation community, we tend to think things are going to happen faster than they do, but we tend to not think about the scale at which it will happen. So we, in the .com boom or mainframes moving to PCs, we thought it would happen faster, but we always underestimated the outcome that would come out of it. So I think we're probably doing that with AI. Tell us, how do you think Arcadia, you guys have been in the business for a long time. Catch us up on what you do for healthcare today. And then how are you helping with that transition to this next big thing that we don't even know what it's going to be when it grows up?
Yeah, when we started the business in 2009, our mission was deliver on the promise of data-driven care. Connect disparate systems, create a longitudinal patient record, and allow that to be the foundation for a lot of clinical decision-making. In a lot of ways, that's exactly what we do today, 17 years later. We've added a bunch of capabilities on top of that to help bring more intelligence, more insight, increasingly automate a lot of that work for our customers. And as you think about our role in this ecosystem, we become this orchestration and control layer. As you think about the speed that you observe that health systems and health plans are moving, just buying things, that will slow down. Governance will catch up because at the end of the day, there are financial pressures. There is a budget reality. We can't buy everything we want. And there's going to be a real question of how do I evaluate what's delivering real margin, real ROI, and what's not? And how do I bring more structure? And how do I don't want to say, I hate this adage, like slow down to speed up, but there will be a little bit of a slow down to speed up moment. I was just talking to the chief data officer of a pretty large regional health system, probably a 12 hospital system in the Southeast. And I asked him, like, how are you helping your organization deploy agents safely and responsibly? How are you managing the fact that AI is just a reflection of humans? We were talking about data breaches. The MGM data breach was a threat actor, got to a help desk, got a password reset. Agents are just reflections of us. How are we helping to measure their efficacy, their productivity, their safety, their compliance with policy? You train these agents on a knowledge base and you have to test that they're actually not drifting. And so that's a big part of how we become part of this solution evaluation, deployment, safety, security. We've spent a lot of time, 17 years, figuring that out in this ecosystem. And that's where we're going to continue to play. We want to be an accelerator to deploy AI, to measure it and to make sure that it continues to work for you. And we want to make healthcare's tools work better for healthcare workers, not for healthcare workers to work for their tools. I'll wrap with this comment, which is I'm very excited about the concept of a headless EHR. It's something we've needed for a long time. Physicians need to return to the joy of practice. And the only way we're going to make that work safely, securely, and ethically is to have a control plane to manage that.
So we both brought up the word governance, and it means different things to different people. To me, the fundamental utility of governance is that it helps you make decisions faster, right? And that's the good thing about data is good data helps you make decisions faster. What do we need to do to help our CIO, C-suites, and others with these data? Is it more ontology? Is it more kind of like what the Palantirs and the C3s of the world do is they help bring in data, but then build the ontologies. Now, we've had the ontologies for a while. We've had HL7, we have OMOP, we have FHIR. What's lacking in this comprehension world that you think might help these guys out to make decisions faster?
I think, honestly, it starts with a business problem. I don't think we need more ontologies. That's for certain. I think we need to continue to break down silos and create much more longitudinal integrated views. It used to be the case that you had vendors who would bring together like supply chain and ERP data, and that would be one kind of clean, normalized evaluation set. Then you would have like your clinical database. Then you might have like claims or billing and charges in a rev cycle. And the opportunity now is bring that all together, get a full end-to-end view. If you're going to go implement a new AI solution that's helping you prepare for surgeries more effectively, get the right surgical kit, track and monitor, what implants are in which patients, bring it all together. It's not just supply chain. It's not just rev cycle. It's clinical. It's ops. How do you create that single data plane that rules them all, that allows you to deploy these technologies and measure them effectively? So you can start to measure not just the impact on employee or provider or surgeon satisfaction, but what's the impact on your rev cycle? What's the impact on collections? What's the impact on patient satisfaction? What's the impact on margin? So you can start to have like much brighter multidimensional analytics around the impact, because that's the other problem is, healthcare is huge industry. We already talked about how much of the economy it's taking up. You have specialists, you have the people who are focused on quality and safety, and then the people who are focused on rev cycle. But now we have an opportunity to say, let's focus on all of it. Let's spin the cube on all dimensions to get to the right view of what success and what return looks like.
So one of the biggest challenges you guys have, and not just Arcadia, but all of us in this data community is, and we got in the last minute that we have, just tell us, fill in the following sentence. Great ideas, Mike, but I already have my EHR. They're going to handle all this for me. How would you answer that question?
If that's where you're starting, you've already lost the race. The EHR is a fantastic tool, but I think in 5 or 10 years, you will not have people sitting behind a computer screen typing into an EHR. The travel industry is the best analog for this. Sabre still processes every airline reservation. It's the reason we have a 6-character record locator, but it sits behind apps. And increasingly, you don't even need apps. You're going to be able to talk to a voice assistant. I've told this story a few times this week. My provider is a concierge provider. I sit down in her office. She's got a big TV screen on the wall. We talk about what my functional goals are. She's got an ambient scribe listening. It's doing all the administrative work. And we're able to talk about what's important to me as a patient for my health span. And she's able to help me navigate improving my health, which is why she became a provider. And that's the future we need to strive for. EHRs are billing and CRM platforms, and they can fade to the background. We'll need that transactional layer, but they're not going to be what they are. I think in faster than 5 years. But again, that's the innovator's dilemma. We always think it's going to be faster than it actually is.
That's right. Awesome. Well, Michael, thank you so much for taking time out of your busy schedule at HIMSS to share your insightful perspectives with us. We'll hope you come back and talk to us more about how you're making these great strides coming up later this year.
Can't wait to come back. Thanks for having me today. Happy HIMSS.